Good morning, Dr. Vijay, Trehan and team.
Good morning.
We're all, you're all
Good morning to you.
And please just go back. Please just go back to the history. It was very quick. Can you just go back to the history? Can you please just go back to the history? It was too quick.
Let me introduce the team which I have. I have Dr. Kathuria with me on my right, Dr. Safal again on my right, Dr. Anshu. On the technical side, we have the Mr. Sushil. He's our senior most technician, and Dr. Kathuria will let you know about the clinical detail of the patient.
So, good morning everybody. He is a 58-year male. He had a history of a non-STEMI MI and he was stented in October 2016 in another center. He was okay for a month and then he had increasing angina. So he presented to us with complaints of class 3 angina. ECG was within normal limits and echo was showing no regional wall motion abnormality. And this was the angiogram. So you can see there is a diffuse LED left main disease, bifurcating disease. Important thing to note is it's a left dominant system. Next slide please. And you can see that the ostium of LED is spared. So it's a type of in-segment stenosis which has come up and the stent is flowing well. We don't have the previous angiogram where we can say whether there was a disease previously present or not. And you can clearly see the left dominant system with a sparing of the ostial LED and an ejection fraction which is normal. So we're proceeding ahead with the case.
And also this is left dominant.
So that.
So what is your
That's
plan?
Right is pretty small. So we first did the angiogram again today. I think you are able to see the angiogram. This is the left EBU catheter, 7 French, which is there, and we are able to see the same disease. What we see is there is one more branch which is a very high OM. Next please. Next scene please. So this is the aleocranial, which tells that it's a real in-segment disease. The stent looks okay, and however we really don't know as to how the stent is going to perform. It is just only 3 months, or whatever. We have a disease in the left main stem. The ostium, at least angiographically, not bad, and then there is crowding up of multiple branches other than LED and LCX. So we have high OM there, which are coming. Angiographically, we are not very clear as to what is the exact origin of these vessels. Next. So we took a couple of more shots. Show it please. So again, we are not very wise. What we know is that the high OM or ramus, which is again dividing. Next please. So we wired in the aleocrane. Was pretty easy to get into the LED. Next.
No, what is your plan, sir? What you have decided to do? Single stent? 2 stent?
No, we first do the intravascular ultrasound. We will first do the intravascular ultrasound. Previous.
You want to see whether disease is extending to the circumflex?
Yeah, that's what it is. So we had a VAR in high OM and also have a VAR deep in LED and circumflex. And then we took first a IVUS run from LED and then subsequently from LCX. Let's see the IVUS please. I was there. This is getting oblique. Cameraman should be straight. Yeah, can you see I was there please?
Yes.
Yes. Very much.
Dr. Yadav?
Yes, sir.
Yes, very
Can you
much.
see the IVUS?
Yes, sir.
So this is a pullback from LED. The stent looks to be quite okay. It's about 3 millimeter or maybe 275 stent. The vessel looks 3. Next, as we get proximally, you see that
Tight stenosis.
you get a lot of chunk of atheroma proximal to the stent, extending also into circumflex. And that is the left main, hardly any lumen. And as we pull it further, left main looks about 4 plus, 4.5. And as we go towards the ostium, the atheroma burden decreases. And right near the aorta ostium, it looks reasonably okay, but still there is atheroma, so we'll have to cover it from the ostium itself.
Sir,
And we are there in the aorta. Next. Then we have a journey from circumflex.
But with the
IVUS,
LED
please.
to left main, your IVUS, circumflex ostia looks clear. There is no atherosclerotic plaque there.
No, okay,
Hospital
doesn't matter.
looking
Let's
okay.
let's better see it from circumflex itself. Let us see from circumflex itself. Circumflex, which is looking pretty okay, has atheroma burden which is around 40%, maybe a little more than that also. The vessel looks to be about 275 to 3 millimeter, proximity is 3, and you still see that atheroma burden which was not seen angiographically. And as you approach left main, you find there is a significant atheroma
Significant stenosis.
eccentrically placed starting from 9 to 6 o'clock position, sparing 6 to 9 only. This is a pullback going on, and there you get into the left main. So, may have opinion of the expert panel there. With that kind of atheroma, at least angiographically, which is not very clear, and IVUS shows there is an atheroma, which is
Yeah, I was
filling
actually
about
in my mind, I think.
maybe
we need to
60% of the cross-sectional area.
I think if I have not done the IVUS, I have put the provisional stenting technique, but with the IVUS result, I need to stent. So definitely
So
the
you need
value
to
of
stent.
imaging is there.
Is that the opinion of the house, or
I think what we feel personally, but I don't know what is the opinion. One stent, two stent, two stent. One stent. How many one stent? Only few one stent. Most of them want now two stent after IVUS. But before IVUS, what was the opinion? One stent, two stent. So definitely the value of imaging is there in left main, particularly with the, although it looks okay in the side branch, but it was diseased and quite extending more than 2, 3, 4, 5 millimeter. That means you need to stent technique.
so does anybody agree that we
Yeah,
go
now
provisional as
everybody
far as
here
two stents are
agreed for
concerned,
the
or
two
we are
stent
committed to
technique,
two-stent
sir?
technique? Two-stent technique, okay.
Yeah.
If we want to go ahead with a two-stent technique,
Which
at least
technique?
angiographically, can we show the runs, please? Next runs. Let us just show that we did a dilatation in the area of interest with a 3.5 NC balloon. We went up to 20 atmospheres. Next. So that's how it looks. It looks better. There is no area of dissection. And if we want to have a two-stent technique, what kind of technique the house will like? Next, please. We are trying to separate out the ostium of the circumflex. Next.
So what technique you will like?
Because if you are able to really see
DK
this,
cross, culotte, or T stenting. Means tap. So some people said culotte, any DK cross, or some mini cross or DK cross, were just similar. So some people, most of them favoring mini cross or DK cross.
culotte,
Sir, most of them
culotte,
favoring.
I think there is a marked disparity in this size.
Yes. So there is
At least
marked
from
disparity.
circumflex to
So
left
one
main,
of the mini
at
cross or
least
DK cross
angiographically.
technique will be the choice. Or tap technique, will it be okay,
What
sir?
about if it,
The result of tap is not like that of DK cross or culotte. All the trial was done with the culotte versus tap, and tap was inferior to the culotte. But no trial has been done with comparing DK cross versus tap technique. So, but anyway, if it is culotte, but in left main, culotte versus DK cross was done, and DK cross is superior. So definitely the tap technique
Okay.
is inferior. What I mean, tap technique is inferior. So if we will do, we'll do DK cross. And advantage of DK cross over mini cross is the
Not a
recross.
domain of
That's all.
culotte.
Result is similar.
okay, with that, do you think we really need to prepare the circumflex bed? Because I think the stent can easily go into circumflex because
No
at
need
least
of
LED stent is
pre-dilatation.
not projecting
Looks okay.
till the bifurcation, and so we can be direct with the circumflex with a stent which is maybe close to 3 millimeter in diameter and about say 12 millimeter or 13 millimeter length. Is that okay?
Yeah. The only thing is that there is no calcium in the side branch, so okay, you can go directly and you can stent it. But the only thing, you can't go high pressure, it may dissect in the outflow, that's all.
And what kind of a stent do you think will be sizing for LED? I think the length is close to about 18 millimeters, so we can take a 20 millimeter stent.
Yes.
And since the LED is about 3.5, so I think we can take a 3.5 into 20 millimeter stent there in the LED, from left main to LED. Is that okay?
I think you are taking 3.5 or 4? I will take 4 millimeter stent into the
I
left
think
main
because the LED,
and will deploy at less pressure if required. And then we'll go with the 4 millimeter balloon.
3.5 with the 4 millimeter balloon is okay.
No, 4 size is 4. LED is quite big, and 4, it will take 4 easily.
yeah, we can take a 3.5 stent, which we can later on
Increase
blow
to
up
4.
with a 4.5 millimeter balloon.
Yeah.
Is that okay?
Yeah.
Okay, then give me a, is that okay with the house?
Yes, yes.
Ready stand first.
How many 4, how many 3.5?
Okay, then give me a,
Synergy
Because
312.
in your left main,
so
the
I am taking,
stent has to be 4.5 around. And 3.5
so that
you can
3.5
blow.
millimeter stents can easily be blown up to,
Yeah, you can blow, but the covering area will be less. Metal covering area will be less. The space between the holes will increase. So if I have to do, I will take 4 millimeter stent into the left main to LED, and side branch 3 millimeters, 3, 15 or 16, whatever.
actually we like to do the, so what is your opinion on the house? Should we go, because I don't think it's really
You don't go high pressure with the left
great
main
matter
LED
of
stent.
conflict as well as 3.5 and 4. Yeah, but then of course, if you are taking a 4 millimeter stand, we'll have to be a little low as far as pressures
Yeah,
are
lower,
concerned, deployment, and if we are taking 3.5, then we can go at reasonably
Don't go
high
high pressure. When you
Okay,
deploy the
then we have
left
a
main to
4 into
LED, you
20
just
synergy.
deploy at 8, 10 atmosphere.
This is L6.
It will not dissect the outflow of the LED.
L6.
So 312. 313. Farhak.
I think circumflex stent you can take slightly longer.
313.
Yeah, 15, 16.
Just a second.
This earpiece is gone by. Audio visual, ये कान से निकल गया.
Then usko bulao jaldi.
उसको बुलाओ ना, निकल गया कान.
So we go ahead with the L6 first.
So somebody was saying circumflex we can take a long stent. How long? Because
Not long,
I
15,
think
16
Asrama was
is
pretty
enough. Up to 15
still a
is
long
enough.
distance.
15, 16 will be enough, sir.
So what?
Till it reaches the OM1, small OM1.
Okay.
Yeah.
We take a 3, no, 13 दीजिए.
313.
Quickly, because time is going quickly. जल्दी से निकाल दो.
No, what is the length of disease in the IVUS in the circumflex?
So we are taking,
Prepare.
hold it.
So you have decided mini crush or decay crush, sir?
चढ़ाओ दूसरा उसके ऊपर. I'll go for a so-called mini or micro crush. Try to have as little crush as possible.
Stand दीजिए.
So
Synergy
this is a
420.
3.5 stent. Sorry, 3 millimeter into 13 millimeter. This is a fire arc stent, which we have started to use off late. This is a stent which is something like Synergy. It has a abluminal coating, and unlike many other stents, this abluminal coating has a drug which is 1/3 of the drug which is with most of the other stents, because this coating and drug delivery system is in a ridge, and so it requires very less dose. So 1/3 dose has been shown to be as good as is 3 times dose. And also the polymer is about 1/5, because they have cut a well into it or ridge into it, and the polymer is also about 1/5, and they dissolve. The polymer degrades over a period of 9 months. This is a hit stent in China market, and last year they have deployed about 1.7 lakh stent there, And they have a head-to-head comparison with Science in about 18,000 patients in different registries, and late lumen loss has been found to be non-inferior as far as Science is concerned, and subacute stent thrombosis is less than Science. We in India have not been using this stent, but in the last few cases I have used this stent, and I have found it to be quite okay as far as initial part is concerned, but I have to rely on the available world data which says that it is non-inferior. So in such a situation it is always good to have a LED stent little distally, and just because you can run into trouble, so the stent which you want to deploy later on, I always say that the inflation device, either you do not connect the inflation device or you keep the inflation device away so that there is no room of error. So you don't, even by slightest of mistakes, can inflate the left main LED stent first. So you either don't connect this or just keep it away. And also have this stent a little distal, because it may still be possible to pull the stent, but sometimes it may not be easy or even impossible sometimes to push the stent in case your stent is more into the left main. May I have a test, please? Some good testing.
Pull the LED stand more.
Test, please. That looks little into the circumflex.
Yeah, I think slightly.
Let us check in the allocranial,
into the
please.
left main. If you want to cross
Quickly
it,
allocranial.
slightly, it has to be.
Back. Okay, test please. So there is a very slight room. I can pull it about half a millimeter more.
I think there is a gap between the stent and the marker.
Small test please.
1 millimeter at least gap, so you have to more inside the.
We can see the stent which is about a millimeter distal to the marker.
Yeah.
Small
Yeah.
test. I think that looks okay to me. PA caudal. So that is something like a micro crush for me, because it's going to be very little crush here. LA caudal, please. Here, of course, in this PA caudal view, you really cannot make out as to where is the ostium of the
I think we
circumflex.
can pull the LED stand slightly more.
That we can do,
wants to
but I
pull
think
it
at the
later
moment, okay. In short, please.
This looks okay.
I think it has got pulled little more, or the house agrees this tend to stay there.
I think eleocranial, please again.
Eleocranial
About the
is better. So
Allocrane, please again.
Yeah.
Yeah, allocrane was better.
Yeah.
Okay, shoot. So is that okay?
no, so
Or I push the stent a little into the circumflex.
Yeah, it's okay.
This looks okay.
Perfect.
Small test.
Because there is a gap and quite inside.
think you're
so
good.
it will cover the
Okay, going up.
Good.
ostia properly. Maybe 1 or 2 millimeter inside.
Low pressures first. How much?
8.
8, 10.
Mini crest.
Deflate. Now what I am doing is take a small test. Just check the, yeah, that things look okay. I have pulled this balloon a little bit. Go ahead again. Inflate.
10,
12,
12,
14.
14.
Deflate. Then maybe 18 here.
Done.
Deflect. So this circumflex stent is well deployed. There is not too much of sucking in of the guarding. Small test. Which is a circumflex wire.
This is the circumflex.
So now I'm pulling the wire and seeing till this place. Okay. Shoot.
They can pull it.
That outlet of the stand looks okay. There is no obvious dissection. PA caudal, please. Just to check in some orthogonal views again for the circumflex.
Boost, sir.
I'm pushing the guide a little in.
Stand boost to your lab.
Shoot. So we have had some pinching of the OM, but there is nothing as far as distal edge of the stent is concerned. We can take care of it a little later. So at least for the time being, the job of this wire is over, and I just pull out the wire and the stent delivery system. And now I have to, just a moment. Now, which view of the house will like to have the ostium of the left main nailed? Small test. Test again. Okay. Test. Go to iliocranial, please. Oh, give me that wire again.
Yes, sir. The wire again.
Small test. Elio come kariye, please. Less elio or less elio. Small test. Small test.
Looks okay.
Down isko piche rakho. Small test again. I think is okay as far as
I think it's
left
okay.
main is correct. Very small test, please.
Yeah.
Okay, go ahead. Deploy the stent.
Going up.
Yeah. 6, 8,
8. Holding.
10,
10.
12,
Holding. 12.
14,
14.
16,
16.
deflect.
Deflated.
What is the length of the stent in the LED?
20.
This is 20 millimeters
20
stent.
millimeters.
Inflate again. Got high pressures.
20 done.
Deflect. Now I'll need a 4 millimeter or 4.5 millimeter balloon.
4 millimeter balloon, please.
We can check for anything unwanted distal to the stent, but relatively less likely because it's a recently deployed stent in the LED, so it is unlikely. At this moment, it is important that we don't let the guide get sucked in, so we have to pull the guide while we are trying to withdraw the balloon, which has been done in this case, and now the guide is sitting just close to the ostium, not really sucked. Give me a 4 millimeter balloon, please.
Pot.
4.5. Okay. In the meantime, we take a check shot just to see 4.5 chada.
Yes, sir. The balloon, please.
So, left main LED stent as well as circumflex stents, they look okay. And in fact, whatever was looking very good as far as LED stent is concerned, it has started to look, at least angiographically, not that good. But I think that is a visual phenomenon. We have to just take care of the area which we have handled. Now I'm going with a 4.5 millimeter balloon, which I'll first try to go at high pressures here. Go up. This is somewhat outside. Go up.
12.
18, 28, 22.
22.
Deflect. Go to LO caudal, please, or PA caudal. Or just hold on there. I can just walk into this. So if you see here, small test, it is somewhat difficult to define as to till what place you have the LED ostium, because I will not like to walk too much beyond the LED ostium. Go back to iliocranial. So I think the part has to be done till the carina, small test. I think I'm okay as far as spot is concerned. Go
You are
ahead.
in perfect place.
15, 16, 18.
Deflect, deflect, deflect.
Do you have
This
stent
was,
boost, sir, in your lab?
Like 18 atmosphere here. Yeah, we have that. We'll just show you.
So you
So
do the
go up,
stent boost.
go
You
up
will be
again.
able to see where
So
to
that was
recross with the
18.
wire.
14.
Yeah.
Recrossing the
18,
side
sir.
branch,
Deflect.
I think it will be from the
So
proximal
give
part.
me the wire.
Yeah. Same one?
Yeah. So whenever you have a stent in the side branch, just to avoid things getting underneath, it is always preferable. Again, the same thing is happening. In fact, this will be more if you take a bigger and a non-compliant balloon, that second part. Give me a bar, please.
Sir.
Bar. So now the pot has been done,
Water.
and we'll give me the bar again quickly.
Yeah.
Now, cranial only.
Yellow cranial, please.
Now, anybody who can suggest me as to how to cross proximally?
Yeah, you have to cross in the proximal part of the side branch. Proximal half.
No, that's all right. That's all right. But so my view for this is allocranial. I think
Yeah.
in allocranial view, I can still have an idea. So if you want to cross proximally, have the wire directed towards the circumflex first. Like this, and then maybe you slide it downward. So that's how you can possibly enter from the proximal strut. Is that okay?
Yeah. So proximally, there will be one
Cordal.
struts only. That's why in like this, you have to cross from the proximal part of the side branch.
Small test. Okay, give me a bit for the circumflex.
So 1.25 balloon.
बड़ा-
1.5
बड़ा-
balloon,
नहीं, नहीं,
please.
बड़ा- बड़ा- बड़ा। ढाई का दो।
ढाई का balloon दीजिए, please.
Quickly. Keep 3.5 and 3 non-NCs. ढाई का non-NC. जल्दी से दो यार, इसके लिए वेट थोड़ी। इसको छोड़ने का कोई। Give me the.
Attention of the expert.
So I'm taking a
Anyone-
3.5 millimeter non-MC
Yes,
balloon because
we do-
MC I find
Just 2 to 3 minutes before the end of this session, Goel will come back with results
Okay.
of the previous case. Thank you.
hold it. ये डाल के देखो. Okay, give a 3.5 उस पे
3.5, please.
NC और 3 इसके ऊपर NC बाद में.
उस पे
चलो.
3 NC डालिएगा. 3.5 NC डालिए, please.
चलो इन्फेक्ट करो. It has walked in very easily. 3 का NC इस पे चलो. 3.5 इस पे चलो.
हाँ, चला.
Inflate please.
Yes, sir.
How much?
14.
18, 20.
18-20 done.
Deflate. चढ़ो उस पे जल्दी से.
हाँ जी. और मुझे एक 3 का NC यहाँ के लिए दीजिए. हाँ जी.
ऑक्स बलून दे रहे हो?
3 का NC, please. 3 का NC दीजिए, please.
So what size balloon you are taking the left main to LED for kissing?
I am taking a 3.5 balloon for LED because the size on IVOS was 3.5.
Okay.
And I am taking a 3 millimeter balloon. Just leave it, please. Pull the wire. I'll take a 3 millimeter balloon for circumflex because the distal circumflex was about 2.5 to 275, but as I was approaching the ostium, the circ was 3. So I'll take a 3 millimeter balloon for the circumflex. And this is a common thing, which is, we can see it here. We see that the wires have got twined. Now, how to get over this twining of the wires?
Is there, yeah, there's some volvulus there.
Anybody has any bright idea about?
Bring the other wire proximal to the floppy part and you might be able
Which
to.
one? Which one?
The
Which one?
circumflex wire. Bring
which
the
one? Which
circumflex wire back.
If I have to back, I will
Okay.
back the LED wire.
Okay, so it is always better. Yeah, it is always better. Yeah, it is always better. Give me another wire for circumflex.
The other way
more
obviously
wire.
would be a
One more
crusade
please.
catheter,
Choice
but
floppy wire.
that would make it more complex.
Yeah. Give me another wire quickly.
Another wire, please. Another choice wire. Thank you.
चलो इसके ऊपर बलून भी ले लो फटाफट रहने दो.
The 3 balloon.
Now, having had a hole in the circumflex, it will be not very difficult and we'll not have to possibly choose so much. And this is going to walk in, go to LO crane please. Yeah.
This is the problem with the mini crush. Even wire goes easily, balloon may not go. That's why modified into DK crush, which is easier, where balloon and wire goes very easily.
So
Yeah, go to PA quadrant, please.
keeping the
Take the
shaft
party.
of the balloon in the LED
Yeah.
will
No, no.
prevent revolvulus as you are elegantly demonstrating here, sir.
Just in 3 minutes from now, this case will be
That's
offline.
very, very important. Very, very
Your
important.
Experts panel, and then as if you
Yeah,
want
we
to
are-
interact with the
we'll be
operator and
finishing
your
in 3
audience,
minutes.
this case will be offline in next 3 minutes. Thank you.
I think it will be done within that 3 minutes.
Yeah. Leave it. Keep a 4.5 ready.
4.5 balloon ready, please.
So,
It will be
There
done
goes
within
this.
3 minutes, sir. Don't worry. You just go
insert
ahead.
this.
Yeah.
Please carry on,
Yeah,
please.
quickly,
I'm talking
quickly,
about this offline.
18, 20, 22. Deflate. So we have inflated at 22. Inflate this at 20.
The LED,
Yeah, LED 20.
up.
Inflate. Okay. Now what I do is, to have high pressures, it is always better to do something like snuggle.
Snuggle.
Go ahead with the circumflex.
Yeah, otherwise carina will be enlarged quite
And this
wider.
snuggle is to be done at high pressures. Yeah. Now what you do is just take a shoot. That shoot tells you that you are not too much into this. Go ahead. Now this circumflex is 20. Go ahead, LED also 20.
So 20.
So I am 20. This is a usual bifurcation we do at 12. This is at 20. Deflect.
1, 2, 3.
What I find is, if you do an IVUS in these cases, after you inflate both the divisions at 20, the ostia of the both bifurcation limbs, they look better rather than if we inflate them at lower pressures.
Does the
Of course, you
sequence
can't
of
take a liberty
deflation
with,
matter?
4.5 balloon,
DVS.
please.
Does it matter
Yeah,
which
I-
sequence you
I
deflate
feel
the
both of
balloons
them
at?
should be, yeah, it matters. Yeah, it matters. Both should ideally be deflated at the same time. But just in case the result is under in one branch, say the result is under in diagonal, or like if you are doing LEDD1, or the result is under in circumflex, then the branch which is having under result should be deflated later.
Can we see the result
Am I
of
clear?
Dr. Parveen Goyal?
This
in
has been
between?
well studied.
Because we have only 2 minutes more left.
I'm just doing a pot. Can we just take a check shot? I think pot may be done later on.
You just do the pot and pot 4.5 balloon. Yeah.
Ready, ready, ready.
This is a 4.5 balloon. I'll do a pot just for a
Correct.
maybe another 15 seconds because I do pot for a shot. Go ahead. Do pot, please.
Sir.
This is post pot. Quickly, 14, 16, deflate. The balloon is a little pulled. I will go till maybe carina. Go to 16 again.
Done.
Deflate. And still flaring 20.
Done.
Deflate. So there we take the final shoot with the balloon into the guiding. Okay.
Ready.
Forceful shot. So that's what it is.
Can we do an LO cranial shot, please?
Hello, cranial, please. I would have loved to
Eleo caudal.
visit the vessel with IVUS, which we will do it. We'll give you both. Hello, cranial, please, first.
This is the best shot.
Then hello, caudal.
Looks excellent.
Hello, caudal again.
Excellent result, sir.
You see that
You have heard the
Thank you,
applause
sir.
by the audience.
that's
Excellent result.